Very good evening and a very happy new year. 2025. I'm personally looking forward to the year. I don't know what it is about this year particularly, but I have a feeling it's going to be a very meaningful year. So it is my absolute delight in that light to start the year with our very first conversation with Dr. Leena. Welcome, Dr. Leena,
Thank you.
and a very happy new year to you and your family, as well as many congratulations for now being the director at Sukun Nilaya.
Thank you. So,
I'm so excited and delighted for you. I think it is the best thing. I'm so glad. It will only be great for Sukun Nilaya.
thank you so
I
much.
would like to tell our audience a couple of things. So, my first memory of you is meeting you at the parking lot when we went to see the film of Dr. Rajagopal, um, and how. How significant could that be, right? How symbolic could that be? And you telling me that you are a geriatric palliative care physician. And I was like, oh my God, those are incredible three words together. I so want to know more about that, and we will start with that. But I do want to also mention that I had directed a friend of mine and her parents to meet you at Sukun Nilaya,
Mhm.
and she just wouldn't stop appreciating uh, your consultation and the fact that her parents were in a great place
Thank you.
simply having met you.
Thank you
I
so
mean,
much.
those are really powerful credentials.
Mhm. Thank you. Thank you so much. So Bhavna, at the outset, let me wish you as well and all of our viewers a very happy new year. And I'd like to take this opportunity, Bhavna, to thank you very much um, for the work that you are doing for caregivers, because I feel that caregivers um, are the unsung heroes of palliative care, mostly of any care, are the people around the patient who love the patient and who care for the patient. And we see them as our care partners. And even at Sukun Nilaya, some of our most touching success stories of recovery are the stories where there are family members who have been, who are there alongside the patient, who are also able to be empowered. And so and I just want to thank you and everyone at Caregiver Sati for the work that you are doing to empower family caregivers. And so thank you for that, and more strength to all of you. And I hope that in 2025 you can just do so much more. I know you've done a lot, and I hope you just continue to do more.
Yes, no, absolutely. It's great to be in this network, and I often laugh about it. My mother wanted me to be a doctor, but I just didn't have the capability to be one. And here I am in an unconventional route, interacting every day with doctors, and it's been my privilege to learn from experts like you. Can I just request
तेरा
for
वॉल्यूम ऊंचू कर दो
the phone to be on mute? I am sorry.
दूसरी बंद और
I
सर
don't know how to mute Asha's phone. Um,
I think maybe
yeah.
that's okay.
Okay. Sorry about that. I would like for us to start with the specialization of geriatric care and help us and our audience understand, one, what is geriatric care, two, what is geriatric palliative care, and why must we know enough about it?
Okay, so let's start with what geriatric care is. No, I'll take a step backwards. I'll start with what palliative care is. because palliative care is definitely a broader term. And then in palliative care, you would have your pediatric palliative care, which would be palliative care for children. You have adult palliative care, and then you have geriatric palliative care. So I'll start with palliative care. So palliative care is it's a specialized approach in medical care for the care of what we call life-limiting conditions or serious health conditions. And when we say life-limiting, we mean that they would have some impact on either the quality of life or the duration of life of the person who has that diagnosis. So, for example, historically, palliative care was associated with cancer, so people with cancer were offered disease-modifying therapies for their cancer. But palliative care is also offered, or should be offered, alongside for the distressing symptoms and the distressing, the different aspects of a disease that come along with the disease. Okay, so I'm going to just explain this a bit. So historically, it started with cancer, but over time, it was found that of all the people who need palliative care, about 7 to 8% are from the population of people with cancer, but about 92% are people who have conditions other than cancer, but they are also serious conditions. So, for example, neurological conditions like stroke, like neurodegenerative disorders, like dementia, Parkinson's, motor neuron disease. Then there are people with respiratory disorders like pulmonary fibrosis, tuberculosis. There are people with liver disease who would need palliative care. So basically, palliative care, the approach of palliative care is to give comfort and support when a curative option is no longer available to us. Okay, and that's why these are for serious illnesses. So that is the broad term for palliative care. What's very important in the definition of palliative care is, first of all, the types of conditions that we see. Secondly, the unit of care, which is the patient and the family or the loved ones around the patient. Both are very important for us to care for because the entire family is going to be on this journey of, experiencing the diagnosis that has been given to the patient. So the unit of care is the family and the patient, of course. And another very important concept in palliative care is the idea of something called total pain. Okay? Total pain means we aren't looking just at physical pain or the physical aspects of the disease. We're looking at the emotional, psychological, financial, social, and spiritual aspects of that disease. And so therefore, it has a very holistic approach. And the approach is also, therefore, a multidisciplinary approach. So typically, your care team would have, of course, doctors and nurses, but you would have counselors, you would have social workers. Sometimes you have people to give spiritual support as well. So it's a kind of approach which is very holistic. All right. So that is what, and the main aim for us, the goal of care for us is to give a good quality of life to the person and ensure that as far as possible they are free from any distressing symptoms, and the family is also supported in this journey. So that's what palliative care is broadly. As I said, it is available for all age groups and people specialize accordingly. So you have pediatric palliative care, which would be for children, you have adult palliative care, and then we come to geriatric palliative care. Now, geriatric care in general refers to a population of elderly people. We typically take the cutoff of elderly people at 65 years. So people who are 65 plus, and in some countries 60 plus, are considered senior citizens and elderly people. Now these people have special health needs by virtue of their age, by virtue of the natural aging process, right? So just as we do not consider the pediatric population as little adults, okay, we do not consider geriatric people as, just older adults. We have to consider geriatric people as um, a special group of people who will have special health needs.
Hmm.
This is by virtue of just the physiological changes that happen with aging. So aging per se is not an illness, okay? You can have very healthy people at 70, 75, 80, but they will still have some physiological changes to their body just by virtue of aging, okay? So the main thing that aging brings about is there's a couple of changes in our different systems, okay, which just come with aging. And so therefore, for example, an elderly person would be less capable of adjusting to temperature changes, right, than a younger person would. Okay, so that's why during heat waves, elderly people are the most likely to be affected adversely by a heat wave, or they're the most likely to be affected by dehydration, because younger bodies are able to adjust quickly to fluid imbalance, to electrolyte imbalance, to temperature changes, to glucose imbalance. We have what's called homeostasis. The scientific word for it is homeostasis. It's the ability of the body to maintain equilibrium when challenged with external stimuli. So if you step out of a warm room into the cold air, your body will quickly adjust to that temperature. But an elderly person may not be able to do that so quickly, because just by virtue of age, the function of homeostasis has been affected in that person. Okay, and that's why it's just so important for us to remember during heat waves and during cold waves that the elderly people are the ones who are going to find it the hardest to adjust, because their bodies don't adjust so quickly as ours do. So they're the ones who will need the extra blankets, the extra shawls during cold waves. And they're also the ones who during heat waves will need to, definitely be under a fan, have access to drinking water, etc., because they're also the most vulnerable. So that's what geriatric care is. And geriatric palliative care is basically the specialized care for difficult or serious life-limiting conditions that happen in the geriatric age group. So of course, in the geriatric age group, there's geriatric oncology, so there's cancers that may appear in the elderly population. So your treatment options would be different in an elderly person versus what they would be in a younger person. Similarly, there's neurological conditions like dementia. So of course you have Alzheimer's. Most common form of dementia is Alzheimer's disease, then Parkinson's disease, and in general of the other organ systems, okay? And what we call the geriatric giants. So instability, immobility, incontinence, and intellectual impairment sometimes. And then the newest one now is frailty, where you have a loss of muscle mass and bone mass, and therefore elderly people becoming very frail. So those are all the health conditions that we generally work with in geriatric palliative care.
Thank you. Every time I listen to you, I learn so much. And I like how you explain this in the sense that I was thinking about it. I knew, although I wasn't trained to be a parent, but I did know that if you have a little child in your life, there is a pediatric specialist you have to consult. And I knew that there are vaccinations and there is a regular checkup that one needs to do. In fact, I have been thinking about the first pediatric doctor that I had interacted with for my daughter. And I remember him, and I'd like to call out his name, Dr. Vasant in Bangalore. He was fantastic. And he patiently explained to me what I need to do with the child, right? And said, okay, you need to do this, that, and the other. And I was just thinking that increasingly now we have to be caring for older adults. And they have been adults and they have been our actually are role models and people we have learned from, and they have led the way. And we have to soon learn a few things. Okay? So imagine if I came to you and said, my mother is 60 and will, of course, I didn't do this when she was, but let's say I was. And what would you do as, some kind of basic system set up that I should do for a parent who's 60 and slowly going to age? Um, how would I set myself up or my home up?
So for that, there's an acronym that I like to use because it's easy to recall, and then it becomes like a mental checklist for us. And it's the acronym of bringing all the pieces together. And as you know, jigsaw puzzles are not complete unless you have all the pieces together.
Yes.
And similarly, if we're trying to plan care for a loved one, we would want to bring all the pieces together, right? So the acronym is PIECES, pieces.
Pieces. Good
Yeah,
one.
PIECES. So P stands for physical. Okay, so now we're going to look at all the physical aspects of care that we need to keep in mind for the elderly loved one. All right. So we would want to check vision and hearing, if possible. If not, I mean, ideally annually, but if you can really be good at this, even 6 months, every 6 months, but if not 6 months, then at least annually. You'd want to check vision and hearing. You'd want to check the teeth. You want to check dentition all the time. So vision and hearing, you're going to check obviously for the person's acuity of vision and hearing, because poor vision and poor hearing can be risk factors for falls, either in the house, or they could be risk factors for falls outside. A person could be crossing the road, and if they have impaired hearing, and they may not hear a vehicle honking at them, or they may not hear someone coming, then of course they will. So you want to check vision and hearing on a regular basis. Dentition needs to be checked, or in general oral health needs to be checked, because that will affect the nutrition of the person. At some point, if someone's having difficulty chewing, or if there's for example, ulcers in the mouth, and this could just be corrected with something as simple as some multivitamins. But your elder loved one might be eating less, and we may not and oftentimes we think this is a normal part of aging, but we have to remember that from our side, we want to prevent the preventable, correct the correctable, and reverse the reversible, right? So you do this. So we start with physical, okay? Again, an annual checkup would include blood pressure. You want to check blood sugar. The Southeast Asian population is at a higher risk for diabetes. So you want to make sure that we have good diabetic, if the person is diabetic, we want to have good control in place, because in the long run, poorly controlled diabetes and poorly controlled hypertension have been found to be risk factors for dementia later on. So early on, you want to make sure your diabetes and hypertension is under control. And yeah, an annual checkup would include an ECG to rule out any cardiac condition that could be addressed early on. And of course, you'd want to check foot health if the person is diabetic. You want to make sure that the feet, which have circulation, it's the farthest from the heart and therefore at risk for vascular changes. You want to make sure that's all fine. So physical so you'd have your annual checkup to check all of these things. You'd also want to make sure that your loved one is getting adequate nutrition. Okay. It's very important that our loved ones receive vitamin B12, vitamin D supplements. What we are getting in our diet is really not sufficient, and it does require extra supplementation, and calcium as well, because we want to prevent, again, B12 deficiency is associated with neurological deficit and is a risk factor for dementia later on. So you want to prevent that with B12 supplementation, and you want to prevent osteoporosis to the extent possible with calcium and vitamin D supplementation. With that, I would say that prescribed exercise is very important. People do not think of exercise often, but more and more there's studies showing that movement is medicine, exercise is essential, and the WHO guidelines for the elderly are about 30 minutes of exercise per day. It can be in tranches of 10 minutes. So 3 times a day you do your 10 minutes. It can be something as simple as walking, walking in the house, going downstairs. I know that the Bombay roads aren't safe, and Bombay sidewalks with those interlocking tiles make walking very difficult. But to be fair, there are now parks. There are some green spaces out there, some safe spaces to walk. In case that's not possible, then even walking within the house. But 30 minutes of physical exercise. So actually walking. If you can get a static cycler at home, and you do get small models that would fit into small homes, they're just the peddler, but we use those at our center, something like that. But 30 minutes a day, okay? And
Would it be yoga as well?
Yoga would be part of the stretching part, so that would help with flexibility. But exercise where you actually challenge your heart rate and you also challenge the joints a bit by walking, okay? Because sarcopenia, which is wasting of muscles associated with aging, and osteoporosis, those are both because of weakness of the muscles and the joints. Muscles in the bones, sorry. And so remember, if you want to strengthen your muscles, you will strengthen them by actually lifting things, by moving things. So what I say to my elderly patients is, if you have 1 liter bottles of water at home, or 1 liter, 1 liter bottles or 1 kilo jars with dry pulses in them, you can use those as your weights and lift things over your head to strengthen. I had a colleague who used to say that he tells his geriatric patients that if you're going to read a grunt every day as part of your prayer, at the end, close the book and lift the book over your head. And let that be some of your weight bearing, just exercise. Give your muscles a bit of weight to lift. Okay. So exercise. I'm still on the P of pieces, by the way. Exercise. Sleep is very important. Okay. We need to have good sleep hygiene. I think these days we have taken for granted the fact that sleep is so important for us. So we need to have, an early night in if possible by 10. We need to try to avoid looking at devices late into the night, because devices tend to emit blue light. Blue light is very stimulating for the brain, so it's hard to fall asleep if you've been looking at your phone or TV for a long time. And I say to people, try to reduce your screen time and try to increase your green time. So if you can be in a garden for some time, do that, and try not to be looking at screens all the time. So try that. So that's sleep. Sleep hygiene is also very important. So that's the P of pieces. I is intellectual. We want to have intellectual stimulation. A lot of people after retirement, it's really important to try to take up some kind of activity that keeps you intellectually engaged. Okay. Of course, solving crossword puzzles, math, Sudoku, things like that are, of course, really good. But also socially engaging with other people, is also very good for the intellect. Music. Even if you didn't learn music before, because raising a family, having a career, all these things kept you busy. Post-retirement, you could probably take up something like singing classes or playing an instrument. It's really good for the brain to set up new networks and learning new things. Language is also very, very neuroprotective. There are studies showing that people who recover from stroke, those who spoke more than more than 2 languages, recovery is often seen to be better. When you learn new languages, you do something called building your cognitive reserve. So there is something in the brain called cognitive reserve, which is the ability of the brain to, sometimes bounce back when it has some challenges. And this is called neuroplasticity. And that's basically the technical word for the brain being able to form new pathways and new recovery modes, sometimes following some kind of injury or insult. So language is protective, music is protective, learning something new. So that's the I of pieces is intellect. Okay, E is emotion. We need to address the emotional needs of our elderly loved ones. We need to stay socially connected. Okay, social connection is really important. Social isolation has become the new risk factor nowadays. Loneliness is a risk factor. So we need social connectivity. We need meaning in our lives. We need purpose in our lives, right? We need to be able to wake up in the morning and think today's going to be a beautiful day. I'm going to call about one or two of my friends, connect with people. So emotional needs need to be addressed. So that's PIE. C is capabilities. We need to understand with our elderly loved ones what their capabilities are. What can they still do? And what will they find? What is difficult for them to do? So, for example, you may need to take a call at some point that driving for your loved one is not safe in this city. Okay, you may not want your loved one to be driving, not because they cannot drive, but it's just unsafe. Their reflexes might be slower. There might be, it might not be safe for them to be driving. So there's some things which we have to honestly say we cannot continue with this activity now, but there's some things which still can be done. And so what we need to do is honestly, stop doing what is not safe for the elderly person to do anymore, but compensate for that and build on what they can do. Okay, so they might want to take up a hobby. Somebody who liked knitting and crocheting, if at some point with age and age-related changes, the fine finger movements start getting affected, she may not be able to knit anymore because maybe that's a very fine activity. But she might still be able to work with color and fabric. So she might like to work with patchwork. She might like to do something like macrame, which works with thicker rope. So find something else that can be done. If you feel it's not safe for your elderly person to be in the kitchen cooking on their own, maybe you can let them help, definitely let them help with planning meals, but also doing things that don't involve heat and sharps. So maybe helping with shelling peas, with cleaning maypea, at least engage them in ways that they still can help. So C is capabilities. E is environment. So you want to make sure that your loved one's environment is safe. So you want to make sure that your house is fall proof, right? So you want to make sure that the bathroom tiles are either roughed up a bit or have anti-slip. You get these anti-slip
mats.
stickers or mats. Yeah, that's, thank you.
Yeah.
Mats. So you want to make your bathroom anti-slip.
Yeah.
You want to make sure that if there's any rugs or carpets in the house, they do not have edges that are coming up and that could trip someone. Preferably, you want to remove chairs from the house that have wheels. Like a lot of computer and office chairs have wheels, right? But those can become dangerous for an elderly person who's sitting, and if the chair moves back, there can be a fall from the chair for that. You want to make sure your chairs are slip-proof. Your bed sheets or bed covers preferably shouldn't have those tied-up tassels. You get some decorative tassels on the sheets, and they're knotted in a decorative way. But I've seen elderly people whose toe can get caught in that tassel, and they can have a fall. So you want to just make sure that your house, the environment is fall-proof.
Especially bathrooms and slippery areas.
Yeah.
Balconies.
Slippery areas. A bathroom should have grab rails. It's a good idea to get your toilet seat, have grab rails fitted on either side of the toilet seat so that the elderly person can steady themselves when getting up and sitting down. You would want grab rails in the bathing area so that in case there's any sudden loss of balance, because remember, one of the things with aging, as I said, is that the ability of the body to adjust to changes. So if the person has taken a warm shower or a warm bath, the warm water on the skin can actually sometimes lower the blood pressure of some people and make them feel giddy. So they should have grab rails in the bathroom so that there's something that they can hold on to steady themselves. Okay, so you'd want to make your house fall proof, okay, and in general safe. So you'd want to make sure that if there's any locking mechanism to the front door,
Yes.
And if your elderly loved one is living either alone or away from you or living separately, you need to make sure that you would also be able to access the house in case it was ever locked. So you want to make sure that the locking mechanism is something that's safe and accessible to a loved one. Um, yeah, and so that would just be making the environment safe for your loved one. And the last part of PIECESC is S, which is the social and spiritual networks. So as I
Mm.
said, social networks are really important. Somehow staying connected. In case your loved one is part of an alumni association from their college days, or from if they have an employees association from wherever they worked, it is important to try to make it to those meetings. Let them stay connected. These days with WhatsApp groups, it's a nice way to stay connected with your friends, and they need to be socially connected and talking to someone every day. And of course, the other S, which we add, is also spiritual, and this is where things like your yoga, pranayam, prayer, any centering activities would come in. So,
Faith, I think, whatever your faith is.
yes, whatever your faith is, being connected to that faith, if it gives you strength, and whatever. So, I know in our center, for example, we of course cater to people from all faiths, and I know that faith is such an important thing for them. Like sometimes when I'm on my rounds, my question is usually something like, "How could I make today better for you?" or "How could I make you happy today?" And I've had patients tell me that it's like, I remember around Easter, one of our patients who was with us and had a stroke said to me that I really wanted to attend the Mass for Easter
Mm.
because I've never missed it all these years. And I said, okay, do you know if the Mass is being offered online? Is there live streaming? And it turns out that there was. And so
Oh,
we
wow.
were able to get a tablet for that person, get them a Wi-Fi password, and they watched their Mass from our ward. And then similarly, we've had patients tell us during Ramzan that they want to listen to their prayers during Ramzan, and we of course make that available to them too.
Mm.
And people from all faiths have had, it actually makes them much happier when they're able to connect with their faith. So S
Mm.
for spirituality and social networks. So
Yes.
what you could do when you're planning for your elderly mother is put together all the pieces and think about how you will address physical, intellectual, and emotional needs, how you will identify capabilities, how you will make your environment safe, and how you will ensure social and spiritual networks.
Awesome. This is so valuable. While this is true in general, and this might be something that I, as the primary caregiver or as the long distance caregiver, may want to set up as an ongoing practice, some kind of an infrastructure, some kind of a check-in, I think it is equally important for me to equip myself to be able to do this. So if you were to take pieces one more time, and this time focus on the caregiver or the caregiving environment rather than the older adult, then
Mhm.
that would be very interesting. What is it that I can equip myself with in order to provide good P, for
Okay, great.
example?
So what I would say is, so let's just flip it around now for the caregiver, for the family caregiver or care
Yeah.
partner. So the family care partner also has to bring all the pieces together because, as I said, palliative care looks at both the patient and the loved ones, and we understand that caregivers are on a very challenging journey as well. We understand that caregivers are often, and especially if you're the caregiver to a senior person, then you are part of what we sometimes call the sandwich generation because you are taking care of your loved ones who are older than you, and you're also taking care of your loved ones who are younger than you because you might be caring for children as well. And typically, you may be caring for an aging parent and an adolescent child, and both can be challenging roles for you. So we understand that. So again, let's just take the acronym pieces. So with P, I would say your physical needs. You do need to take care of yourself. Self-care is very important. So you need to make sure that you are also eating on time, you have a nutritious I mean, the same checklist that I gave for the elderly would apply to the family caregivers as well. So you have to make sure that you're making time for your annual checkups, your health issues are being looked into as well. You are setting aside what we call me time, which is time for you to take care of yourself. And go out, see that movie that you wanted to see, go and do some shopping, eat that slice of chocolate cake that you want, do something, for yourself. I would be, again, intellectual. Many times you're still holding a job at the time of being a caregiver, but you might want to have some kind of activities, again, that interest you. So you might want to take up a hobby, something like art or music or something that just helps you unwind. Emotional needs. If you feel that the journey is becoming challenging for you and you need to talk about it, so there are different technical terms for it. We call it caregiver burden. We call it caregiver burnout. Some people think that that has a negative connotation to it, but it's not. We're not being negative about it. We're not suggesting that when you care for a loved one, it's a burden to you in a negative sense. But what we do think is it does take from you a certain degree of energy and bandwidth. Okay, and if you're the only one caring, and if you don't have support systems in place, you can burn out. Okay, and burning out, again, is not a negative connotation. It doesn't mean that you're not good as a caregiver or it's in any way a form of failure. What burnout means is that you are human too. You are trying your best as well, but you only have so much in terms of psychological reserves and physical reserves, and maybe you're getting a little exhausted. Okay, so that's what burnout is. So the first thing is, if you can recognize that in yourself, be kind to yourself, and reach out for help. Okay, most palliative care centers, palliative care organizations have psychologists, counselors, and social workers on staff as well, who can help with processing this journey and coming up with ways that you can cope with these things in a healthy way. It's also very important in your pieces to have a support system in place of people who can step in and be with, now this depends, of course, on how much you need to be present with your loved one. But if at some stage of caregiving, your loved one has become quite dependent on you and needs you to be there most of the time, you need to have friends or relatives who can step in for a few hours a day or for maybe a few days in the month and give you a break so that you can be away for some time, just recharge your batteries, be ready, and then step back into your role as a care partner. Capabilities wouldn't really apply for us, but capabilities in a way would, because sometimes the skills of caregiving are sometimes skills that need to be learned. Okay, and that's what we actually do at Sukun Nilaya. Is when we admit a patient with us, and we have a lot of patients recovering from neurological conditions, we have a family member staying with them, and we actually teach the family member how to care for the loved one at home. So these are skills which
I'm so glad you said that, because I would have intervened and said that we don't learn caregiving in our homes or in our schools or in our professional settings. So, and it is a skill. It's for sure a skill.
It's a skill. It's an acquired skill. It's not an instinct. I mean, you weren't born knowing how to make a Riles tube feed it through a feeding tube, right? Sure. I mean, you need to be taught how to do this. You need to be taught how to do a dressing for a bed sore. And even before you learn to do the dressing for the bed sore, we give you the space to even be able to stand at our side and even see a bed sore. Because maybe that's something you're not. See, what happens is we are healthcare professionals. This is something that to some extent we have seen enough of that it doesn't alarm us or shock us or frighten us. But there are people who sometimes just need to hold your hand and stand at your side and see a loved one with a tracheostomy for the first time, or see a loved one with a feeding tube for the first time. And we are there to handhold for that process, because not everyone can take it. They need to get used to it. They need to actually get used to it. They need to, at some point, be able to hold the tube in their hand and not be frightened of the tube. They need to understand how to feed through the tube, how to keep the tube clean, and every day with the hope that maybe if this person can start eating orally, we may actually remove the tube at some point. But till then, they need to become comfortable with that. Yeah. They need to become comfortable with a dressing trolley. And so that's a journey. So the C of capability is where you learn the skills of caregiving. And I would say to everyone...
May I just come in at this point, Dr. Leena? I would say that I think one of the other things for caregivers, as I have been one, is we sometimes underestimate the emotional impact that the changes in our loved ones can have on us.
Yes.
And that requires a certain quality of emotional mastery and our ability to manage ourselves and our, the emotional turmoil that the new situation might bring, right? That is also capability. Our capability to, work through our emotional roller coasters.
Yeah, absolutely. It is. Yeah, thank you for sharing that. It is. And one of the things I tell everyone is, remember, it's always okay to not feel okay. Like, you can tell someone that, you know what, I'm just having difficulty coping with this, or I can't manage this. And then if you share that with your care team, then it helps us, find out how best we can help the care partner as well. And we try to explore what is difficult and how can we make it easier. Yeah.
I have, Ruchi in the audience makes a great point about the fact that people who have empathy, caregiving may come naturally to them. I think it is true in most cases, but I'd be a little cautious of this because, it is not just that person. So there are a few things here. One, we also have stereotypes. So we assume that women have more empathy, or the story going around the world is women are more empathetic. So that can be a trap. The second is that people who have significant empathy can also run out of their empathy reservoirs. Like you just said a little while ago, that we need to replenish our energies. And empathy is a reservoir that one could run out of as well.
Yeah.
So I just wanted to bring those points in, but please correct me if I've got them wrong.
No, absolutely. And honestly, I'm here, of course, as a medical professional, but Bhavana, you've played the role of a caregiver, a care partner. Many of our participants today have probably also been care partners. So honestly, I think all of us, in a sense, are experts in some way or the other. And so I accept what you're saying completely. I mean, there's nothing to correct there. I agree that we need to be careful about stereotypes. We especially need to be kind to ourselves and not try to fit ourselves into a stereotype or what a societal expectation of us would be. I mean, I remember once I had a family care partner say to me that her mother-in-law was sinking and she needed to go to an alumni reunion that had been organized, and she said to me that she was at that party and she actually felt guilty every time she laughed and every time she enjoyed the moment. She told me she felt terribly guilty because there was this thing at the back of her mind that there's someone in the house who's not doing too well and I'm at a party enjoying myself. And so what I thought was, and I said this to her, I said, I think I admire your self-awareness that you could, that you felt this and you could articulate it. And now let's explore why you needn't feel guilty. Like, who are you measuring up to, or who are you answering to when you say that you shouldn't be? at an alumni association. These are people you've known for years, and maybe you're meeting after 20 years. Like after you all left college, you're now meeting after 20 years. And of course, it doesn't take away from you that you're a responsible and loving daughter-in-law. You spent 2 hours at that party. You will come back to the role that you've been playing. But in those 2 hours, if you laughed and had a good time, then why should you feel guilty? Right? But that's because I think a lot of times we impose a lot of these stereotypes on ourselves as well. So I think the first thing is even the conversation that we are having with ourselves, we need to watch that really carefully. And we need to be kind to ourselves. And we need to, as I said, and as you correctly said, we need to try to be careful with stereotypes and societal expectations or even unrealistic expectations that we may have of ourselves. I mean, there are days when you can take a step back and say that, you know what, today I'm just really tired, or I'm really, I just don't have the bandwidth to handle this right now. So I need to take a step back. And I think if you have that honesty, it helps.
I think C for caregivers, the capability for caregivers is probably a very, very important part of the pieces.
Yes, absolutely.
It's emerging like this in our conversation.
Yeah.
That, we may not have the skills, we may not have the emotional mastery, we may have the pressure of social norms and stereotypes, and we may not know how to navigate those, and we may not know how to take rest. And, there's so many things for caregivers.
Yes.
Thank you.
Yeah. And then we come to the E and S of pieces, just to complete it. So E is environment. So again, a supportive environment for yourself. Create a supportive environment for yourself. Be sure to, have, your little elements of self-care. And as silly as it may sound, but this is just what I'm saying from experience, be sure to, still dress up nicely, wear your, wear the earrings you like, wear whatever you like, wear bright colors, take good care of yourself. In the E for environment, I mean, not only the macro environment around you, but even the micro environment, like your thoughts, the level of care that you're giving yourself, that's important. And S is, of course, social and spiritual networks, where, be sure to stay connected, have your confidants in place, be sure that you have that shoulder to lean on. It can be a sibling, it can be a friend, it can be a colleague you trust, but really have that support system in place for yourself as well as a caregiver.
For sure. I mean, I think it takes a village not just to bring up a child, but to also care for the aging, right? Mm-hmm. And to think that one should do this alone would be so not required. Yeah. As you were speaking, one of the other things that came to my mind was as we prepare, I think it is not just when the person is hitting 60 that one needs to build some of these things. Perhaps some of these things are an ongoing journey, and we kind of build them much younger. As I visited my alumni meeting, or I caught up with some of my friends in the new year, I realized that, I wish I had invested a little more time with my classmates. And so I think it's an ongoing thing, and we should do it in our 20s, 30s, 40s, 50s.
Yeah, absolutely.
Yeah. There's a question from the audience that I'd like to bring in at this point, which is that, what advice would you have for queer older adults? And what could be care that is affirmative for queer adults? Let me just read out the actual question. How geriatric care needs to evolve over time, and how can we build queer affirmative infrastructures for queer elders? So if you could help us.
Yeah. So, I completely agree that healthcare has to be universally accessible to everyone, including queer people, queer adults, queer elderly people. The only thing I'd just like to understand, if possible, is I just want to understand how, at this point in time or at this stage, how would a person's sexual identity be a barrier to geriatric care? Is what I'd just like to understand.
I think good idea. If the person, the person who asked this question is here, so I'm just going to request if
I
they
just
are
want to
comfortable.
kind of
Yeah, if they're comfortable,
understand the question. Yeah.
please, come on. And maybe you would be in a better position to articulate your question than I have been. So sorry about that.
Yeah, hi. This is
Hi.
Dharmesh.
I'm sorry
Uh,
I didn't get you. Yeah, if you're comfortable telling
yeah,
me your name, but that's just because I'm a named
Dharmesh.
person.
Dharmesh.
Dharmesh. Okay,
Yeah,
okay, Dharmesh.
yeah. So I have been trying to understand because I have actually quite recently gotten interested into building spaces for older queer persons
Okay,
because there are none in India, right?
okay.
And uh, the understanding that I have come to is that if we try to build separate geriatric care spaces for queer persons,
Hmm.
then that would require a lot of resources.
Okay.
So, is it possible to build spaces which are inclusive and queer affirmative,
Hmm.
spaces which also cater to non-queer populace, but also, has a spaces for queer persons? Because, of course, there are many systemic issues of homophobia and transphobia that
Hmm.
we will have to look into. But
Hmm.
how do we sort of go on building that, which could, utilize lesser resources?
Hmm.
And would it still allow us, because there is a question of dignity specifically if you are
Absolutely.
an elder queer person. So how do we build that? Because that is something that I'm interested in, and I want to sort of spend my next 5-10 years building that.
Okay, so that's a great question. Thank you. So first of all, I do believe that any spaces for the elderly need to be inclusive. In fact, instead of dedicated spaces for the queer elderly versus the other, I think they need to be uh, inclusive, and not only inclusive, but I believe that spaces for the elderly need to be very well connected with other age groups as well. So, on a personal level, I don't actually believe in, like, for example, the concept of these retirement spaces, right? These new retirement homes. My worry with that is that everyone in that setup is an elderly person. And so there's no interaction happening with the other generations. And so what's happened in the West is people have realized that these isolated spaces are actually not good, and they're trying to bring back what was a natural society of having multi-generational spaces again. So what they're doing is, with the retirement homes, they are actually partnering with a kindergarten, for example, so that you have children and elderly people in the same space, which is what normal society should have been anyway. So I also believe that even for spaces for the elderly, they should be inclusive. They should actually have a mix of ages nearby at least, and certainly spaces for people from the queer population. So Dharmesh, just correct me, since you're working in the space, you would know, you could correct me on this. Would the socially appropriate word be queer, or would it be LGBTQ, or how could I best use the language which would be respectful to all communities? What's the terminology that I could use?
It depends on the people using it. I prefer
Okay.
queer because one, it is shorter and it is inclusive. It's an umbrella term
Queer
and
as an
it.
umbrella? Okay, fine. Okay,
Yeah.
because I mean,
But
I'd rather learn this from someone who's done more work in the domain than I have. So yes, and to answer your question about the access of queer people to healthcare services in general, it is a space that doctors are expressing concern about. I was just at a cancer conclave last month when there was an entire presentation about the access to cancer care for people from the queer population, and how it was found rather alarmingly that their referrals to palliative care were for some reason less than the referrals of the general population. So there are issues with there are concerns about access. There are concerns about barriers to care. And, I'd be very happy, even if after this session, if, we could continue the conversation, because then I could at least understand from you, what is the real situation out there? What is the unmet need, right? And how best can we address this? I would be very happy to discuss this with you further.
Definitely, definitely.
And for sure, please consider me equally
Absolutely.
interested. Maybe what we
Yeah.
should do is just have a separate conversation
Yeah.
to first understand what
Yeah.
might be the cause of concern or any potential sources of pain or anxiety or fear. And then we can look at what should be the right solution. I would be very, very
I'd be
interested.
very, yeah.
Yeah.
And I'd be happy to also put us in touch with, as I said last month, we had a cancer conclave on this, and there was the whole issue of, so there were intrinsic factors where people were worried to approach the healthcare system. So there were internal barriers in their perceptions of how they would be treated. Plus, there were barriers on the side of the healthcare system where maybe they were not being treated or referred in the same with the same criteria that others would have been. So this is definitely something I'd like to discuss, and it's definitely something we need to address.
Yes,
Definitely.
absolutely. Thank you.
Thank you, Dharmesh, for bringing that up.
For sure. I mean, like, I am very grateful because I didn't have that lens.
Yeah, thank you.
There's another question from Vinita, and the question is that over time, over long-term care, the relationship between the older adult and the caregiver seems to change, and there are dynamics, and expectations are always high. How do you engage or manage the changing expectations? Vinita, would you like to clarify the question that I have paraphrased?
Um, I think you've done a great job. So that works perfectly for me. Maybe just one small thing that I would like to add is uh, I've seen, whether you accept it or not, there tends to be, the frustration sometimes from both sides is kind of hanging in the middle. And you could love each other to death, but the frustration about not being able sometimes to make a difference is also somewhere in the middle. And like you said, that's and many times the dynamics just involves two people, right? Everyone else is around, but not really as close and taking decisions as the primary caregiver.
Yeah. So thank you, Vinita, for that question. So first of all, most of the time when we work with families and patients, we do try to identify one person who will be the decision maker for us. And I know that often can put a lot of pressure on that person. But the reason why we need to do that, and we do that and document it early on in the process, is because then there's a stage at which you sometimes have to take difficult decisions. And when that happens, you need to be able to turn to one proxy decision maker, because then there can be a situation where, like, I'm giving you, real life examples that I've worked with. We had a patient at the ICU. She had two daughters. One daughter wanted supportive care. The other daughter said that she would escalate, everything. And she wouldn't, in her own words, she said, "Doctor, whatever is available, give it, but I'm not giving up." And we knew that both of them were coming from a position of love. But one wanted compassionate withdrawal, and one wanted everything that this hospital has to offer. And at a time like that, you really wish that whoever had met the family first had documented who the decision maker would be, because you cannot proceed in a situation where there was no identified decision maker. So having said that, but I agree with you that it can be a lot of pressure on that one person. Having said that, we come back to the thing about the changing dynamics over a long term. So let's just take a step back and understand where this dynamic comes from. So let's take the side of the patient first. So remember that all of us have these core values in us of our individual personhood, our autonomy, a
Yes.
certain purpose in life. Okay. And what can be very frightening for a person who is either facing a degenerative disease or just with age is becoming more and more frail is that this autonomy and personhood starts getting threatened. Okay.
Right.
And these can be really little things, like they're little things that we would take for granted, but they mean a lot to that person. I'm giving an example from my own, changing the position of a clock was hurtful for an elderly person because she felt that that it was her house all these years. That
Right.
had been in that position in the living room all these years. And then her, children got married. One child stayed on with her with new spouse and children. And one day, daughter-in-law feels that that clock doesn't look right there, and I don't like the color. And maybe she wasn't wrong either, but it meant so much. So, autonomy, personhood, purpose. Those are all getting threatened in the individual who now needs care. Okay.
Right.
And the three, and if you get time, I'd like you to all read, because I know we don't have a lot of time to go in detail on this, but there's something called the Eden Alternative. Okay. EDEN Alternative. Okay. Eden Alternative. And it's a non-pharmacological approach. It's a different view of how people can be cared for. Okay. And this is kind of a broad umbrella for most neurodegenerative or elderly people. And it's based on the three plagues of their life is boredom, helplessness, and isolation, loneliness. Okay.
Right.
So boredom is where there's monotony every day. So every day it's becoming a breakfast, lunch, and dinner, and then the space in between. Okay.
Right.
So how do we deal with that? How do we deal with monotony? We try to bring in variety. Okay.
Right.
But we do it in a way that's not too taxing on the caregiver either. So what I say is that if it's just changing the color of the dress that she's going to wear today, like every day, show her two dresses, two whatever she wears. Give a blue and a red and say, what would you like to wear today? Okay, just to break the monotony. Okay,
Right.
helplessness is a sense of receiving more help than you are able to give. Okay?
Absolutely.
That's also very frustrating. So try to find ways that you can make the person feel less helpless. So maybe if we're cooking the meals for them and putting it in front of them and that's beginning to frustrate them, let them participate in meal preparation. Maybe they can't handle sharps and hot things, but maybe they can do things like shelling peas and cleaning methi and coriander and something like that. But let them be engaged with you so they feel they're not a burden on you and that they're not helpless. And the last thing is, of course, loneliness and social isolation. So if we address these three things, that takes care of the that addresses at least the loss of personhood, autonomy, and meaning for that person. Okay. Now let's look at the other side of the dynamic, and that's the family care partner. The family care partner, I think, needs to accept for themselves that they are trying their best. Okay, they're really trying their best. So I think the family care partner, the first thing they need to do is be kind to themselves. Okay, even if no one else is being kind, you be kind to yourself. Okay,
Right.
be kind. I can't overemphasize this. Be kind to yourself and learn ways to find joy in your life for yourself and your loved one. And again, these can be little things. Okay. Like I've given an example in another talk of mine where an elderly person with swallowing problems wanted to have pani puri. Pani puri was not possible, obviously, because the golgappa might. But what we did was we mashed the potatoes, we added the jeera pani to it, we mixed it all up, and then we crushed the puris and put them in the potatoes, and we spoon-fed pani puri.
I love this story, Dr. Leena.
Absolutely.
So love this one.
So find little way, like your measurement of time is going to be moment to moment. Don't measure time by how the whole day went, because the day is going to be full of ups and downs. Just measure moment to moment and try to find joy in that moment. If it's making pani puri for the whole family, and another thing I tell people is please don't have separate menus for your loved one. Just modify whatever is being made for the family. Like, cook for the whole family and then modify that for your loved one. So if it's just, whatever it may be, if it needs to be blended with a little bit of liquid and made into a kind of porridge, do that. If it's pani puri, crush it. You can have pani puri, you can have pav vada with someone with, because you just cut the pav into small like penny-sized pieces of cow and smash the butter and put it on that and let them feed themselves. But there's
Right.
nothing that they cannot have. It just needs to be modified. And
Right.
so, and I would say be kind to yourself. And also learn that the dynamic is probably happening because the other person is very frightened that they're losing control. And
Yeah.
that there's probably an element of guilt. They feel guilty that they're a burden to you, but their their way of expressing that is with irritability. And
Yes.
if you just understand where that's coming from, just understand that it's not about you. It's not even that person, it's the disease process that's doing it.
Yeah.
And if
Yeah.
you can just take a step back and understand that, it might make it a little easier to cope with it. And again, if you feel you're getting compassion fatigue, because that can happen, compassion is like energy. So if you're running
Yeah.
up a hill and you get breathless and your legs cramp, what would
Yeah.
you do? You would stop and you take a break, right? So similarly, if compassion fatigue is setting in, that means that somewhere there's cramps happening, just stop and take a break. Ask a relative or a loved one to step in for some time and you go out and go,
Right.
go to the mall, get yourself something nice, a movie.
That was just so
Dr. Leena, this
amazing.
is
Thank you very much.
Yeah.
Dr. Leena, this is the perfect time for me to do a plug. So, as a caregiver, you need to sign up to Caregiver Sathi. You need to join the support group.
Yeah.
And actually, I will add a couple of other things. One, it's okay to vent. So if you can find a couple other caregivers, either on a support group, especially if they're not known to you, and you can find a way to vent, it's like the pressure cooker venting release. It's okay to do it. Yeah. Of course, you might get, and you will not, in a good support group, people will not advise you. It will be a judgment free, safe place that you
Mhm.
can vent in, and venting is good. Um, you can also have an expert, so like Dr. Leena pointed out, they could be a social worker, they could be a therapist, they could be a counselor, if you want to go to them. But that is if you feel that that's a better thing for you to do. That's the second thing for you to do. The third thing that I totally recommend is for you to think of your caregiving experience as something that could be of value to someone else,
Mhm. Right.
right? So if you can volunteer, all our faiths, whether it is, Sikhism or it's Buddhism or it is Islam or it is Hinduism, propound the idea of volunteering or seva, irrespective of our circumstance. And it is more true for caregivers than anyone else. If we can look at someone else, even in our times of distress, I think it energizes and enables us in ways that we cannot even imagine. So I would just add those two bits.
Absolutely.
Perfect. Thank you. Thank you both.
Thank you. And thank you for coming on.
Thank you, Lily. Yeah.
Yeah. Thank you, Dr. Leena. I think that was a brilliant session. There are so many messages, and we are beyond our time boundary. So I realize that these are questions and they are conversations that we can continually have. There is a lot of content on our website, and we would encourage everyone to have a look at that, and not just have a look at the content that already exists. We are inviting individuals to share their experience,
Mhm.
whether on our podcast, which is Conversations with Gentle Warriors, or as blog posts or articles that they may want to write. We also have a section on our website which is called Heart of Care, which is about poetry, painting, or any other art forms that you may want to display,
Nice.
uh, about your caregiving journey or what you think caregiving is all about, and express in a way. Would invite you to have a look at the website. It is Caregiver Sathi, SAATHI.co.in. Do register yourself and contribute as much as learn from the resources. There are many, many self help tools as well. You're more than welcome to use all of them and give us suggestions of what might be helpful for you.
Well, thank you so much for that, Bhavna. I'll definitely spread the word as well with all of our patients and family care partners.
Yes. I'm particularly looking forward to certain poems and many paintings. Hopefully, let's see. Thank you very much. A very good evening to all of you. Thank you, Dr. Leena. Very, very grateful.
Thank you.
And love your passion and energy. And of course, expertise. Thank
Thank
you.
you so much. It's always a pleasure talking to you. And thank you everyone else who's, who was on this webinar with us and those who will watch it later on. More strength to all of you on your journey of being care partners to your loved ones. And thank you so much for being a part of this. Thank you.
Thank you.